Good afternoon, everyone. And this is Group One. I'm Angelo Bibar, and I'm here to discuss about the case three in our subject Introduction to Clinical Medicine. Case three is a 26-year-old woman present to the emergency department with a 6-hour history of worsening abdominal pain. She states the pain initially was a dull pain near her umbilicus but has since moved to her lower right side. She rates the pain as a 8 on a scale of 10 and crampy in nature. The patient states that she noted some vaginal spotting this morning but denies any passage of clots or tissue. The patient ate breakfast that morning but she states she has not eaten since because she feels nauseous. She denies any fever or chills or any change in her bowel habits. Upon further questioning, the patient states her last menstrual period was 2 months ago, but her periods are irregular. She also states that she was told that she had a vaginal infection a year ago, but does not recall having been treated for the illness. Uh, what is the chief complaint of the patient? The chief complaint is abdominal pain, originating from the umbilicus to right lower quadrant. History of present illness. 6 hours prior to admission, the patient manifests worsening abdominal pain, initially dull pain near umbilicus and radiates to right left lower quadrant, and vaginal spotting. But there's no clots or tissue. The patient feels nauseous, no fever and no chills, and has irregular menstruation. Her last menstruation is 2 months ago. Past medical history. Uh, History of vaginal infection a year ago but does not recall having treated for the illness. Review of systems. The patient is the patient is positive. The patient is has tachycardia, faster heartbeats, feels nauseous, and and that's all. He just but he's the patient doesn't manifest weight loss, fatigue, loss of appetite, fever, chills, no rashes, no pruritus, no skin changes, no difficulty of breathing, no cough, no wheezes or no crackles, no chest pain, but has faster heartbeats, tachycardia, no cyanosis, no murmur, and no palpitation. Has abdominal pain, has nausea, but no vomiting, no diarrhea, no melena, and no hematochezia. Genitourinary, no dysuria, no hematuria, no frequency or nor incontinence. Neurology, no seizure, no loss of consciousness, no convulsions. No joint pain, no swelling of joints, stiffness. Endocrine, no abnormal growth, no goiter. And hematologic is no pallor on palms and soles, and no easy fatigability. Physical examination. General survey, the patient is conscious, coherent, and afebrile in mild distress. Blood pressure is 120/76 per mercury mm per mercury. Heart rate is 105 beats per minute. Respiratory rate is 26 beats per minute. The skin is warm, moist, good skin turgor, no pallor or jaundice, which has capillary refill of less than 2 seconds. HENT is head, ears, eyes, nose, throat is normocephalic. Chest and lungs are SE, clear breath sounds. Heart is uh, tachycardic. Abdomen is abdominal pain and tenderness that shifts to right lower quadrant and has normal bowel sounds. Extremities, no pallor or cyanosis, normal extremities, and no deformities. And lastly, the neurologic exam is unremarkable. And what are the salient features? The salient feature is the patient is 26 years old, female, abdominal pain on umbilicus that shifted to right lower quadrant, voluntary guarding, amenorrhea, has nausea, elevated white blood cells, vaginal spotting but no blood or tissue, uh, history of vaginal infection but not treated, and BHCG is 4,605 MIU per ml. And TVS empty uterus um, has enlarged uterus. The differential diagnosis. As you can see that we have four diagnoses for the patient: ectopic pregnancy, H-mole, appendicitis, and pelvic inflammatory disease. 26 years old can be a positive in ectopic pregnancy, H-mole, or appendicitis, and pelvic inflammatory disease. Female can be positive in ectopic, H-mole, appendicitis, and pelvic inflammatory disease. Abdominal pain on umbilicus that shifts to right lower quadrant can be a positive in ectopic, negative in H-mole, positive in appendicitis, positive pain on lower, positive in pelvic inflammatory disease. Voluntary guarding can be positive in ectopic, negative in H-mole, positive in appendicitis, and positive in pelvic inflammatory disease. Uh, Amenorrhea can be positive in ectopic, H-mole, but both negative in appendicitis and pelvic inflammatory diseases. Nausea can be all positive to the four diseases. Elevated white blood cell can be positive in ectopic, negative in H-mole, positive in appendicitis, and positive in pelvic inflammatory disease. Vaginal spotting is positive in all three diseases: ectopic, H-mole, and pelvic, but negative in appendicitis. The history of vaginal infection can be positive in ectopic pregnancy, negative in H-mole, negative in appendicitis, but positive in pelvic inflammatory disease. UMA beta HCG recording 4,605 MIU per ml can be a positive in ectopic pregnancy and H-mole, but negative in appendicitis and pelvic inflammatory disease. TVS, empty uterus can be positive in ectopic, positive in H-mole, positive in appendicitis, but negative in pelvic inflammatory disease. Enlarged uterus can be a positive in ectopic pregnancy, positive in H-mole, negative in appendicitis, but can also be a positive in pelvic inflammatory diseases. So our diagnosis for this patient is ectopic pregnancy, that she has all the necessary um, necessary features that she may have a ectopic pregnancy. And what is the most likely diagnosis? Our diagnosis is ectopic pregnancy. And what is the next diagnostic step? Diagnostics can be beta uh, BHCG repeat after 2 weeks, transvaginal ultrasound repeat after 2 weeks, full abdomen ultrasound, pelvic examination, check Alvarado scale to rule out appendicitis, urinalysis, and serum progesterone. Alvarado score can be migration of pain, 1, anorexia is 1, nausea is 1, tenderness in right lower quadrant is 2, rebound pain is 1, elevated temperature is 1, leukocytosis is 2, shift of white blood cell count to the left is 1, but a total score of 10. The etiology and initial management of the disease. Ectopic pregnancy is a complication of pregnancy in which the embryo attaches outside the uterus. Most commonly occur in the ampulla of fallopian tube, but can occur in other parts of tube, ovary, cervix, myometrium, or within the abdomen. Ectopic embryos can grow and create pressure and invade surrounding tissues. As you can see, the normal growth of a baby, of an embryo, is in the uterus, but in ectopic pregnancy can be the can be the attachment can be occur in the ampulla of the fallopian tube and other parts of the female reproductive system such as the ovary, cervix, myometrium, or within the abdomen. The normal is in the uterus. This is the bahay bata kung sa Tagalog. Dito ini-implant yung embryo sa uterus. The risk factors for ectopic pregnancy is damage to the fallopian tubes or hair-like cilia in internal surfaces of tube, pelvic inflammatory disease or salpingitis resulting in scarring, most common, infertility, IUD use, exposure to DES, tubal surgery or ligation, intrauterine surgery, smoking, previous ectopic pregnancy, endometriosis, or history of STD or sexual transmitted disease such as gonorrhea or chlamydia. Complication is the most common complication is rupture with internal bleeding, which may lead to hypovolemic shock. Death from rupture is still the leading cause of death in the first trimester of the pregnancy. The management of ruptured ectopic pregnancy is first stabilized with fluids, blood pressors, or for salpingectomy or the removed tube. For unruptured ectopic pregnancy is stabilized OR for salpingostomy or unblocked tube. If ECG is below 3,000 excuse me, gestational size below 3.5 centimeter, no fetal heart tones. Medical management is methotrexate with leucovorin. Mechanism of action of methotrexate is a folic antagonist that inactivates the enzyme dihydrofolate reductase, which interferes with the DNA synthesis by inhibiting the synthesis of pyrimidines, leading to trophoblastic cell death. Siyempre, you inhibit the synthesis of the pyrimidines, hindi niya kompleto yung DNA, which could lead to cell death. And autoenzymes and maternal tissues then absorb trophoblast. You can see the methotrexate therapy protocols. The protocol is medication. Single dose is 50 milligram per square meter of body surface. Methotrexate IM. Multiple dose is alternate every other day. 1 milligram per kilogram methotrexate IM and 0.1 milligram per kilogram leucovorin. Laboratory values, LFTs and CBC and renal function at baseline, and beta HCG at baseline day 4 and day 7. LFTs, CBC and renal function at baseline for multiple dose, beta HCG at baseline day 1, day 3, day 5, and day 7 until levels of decrease. Repeat medication, repeat regimen if beta human chorionic gonadotrophin level does not decrease by 15% between day 4 and day 7. Repeat regimen for up to 4 doses of each medication if beta HCG level does not decrease by 15% with each measurement. And you need a follow-up for beta HCG level weekly and continue regimen until no longer detected. Beta HCG for multiple dose, HCG level weekly and continue regimen until no longer detected. And that's all for our case report. And thank you. And God bless us all.